Greetings, everyone, and welcome to what we're calling the Extra Life Conversations. I'm Stephen Johnson, co-host of the Extra Life series and author of the book. We hope you've had a chance to watch episode 3 of the series on the past, present, and future of using data to extend our lives and reduce our existing health inequalities. If you haven't seen it, the series is streaming at pbs.org and on the BBC iPlayer right now. I want to start by thanking the CDC Foundation for helping us put these virtual events together. I'll have more to say about them at the end. And also thanks to the publisher of the book version of Extra Life, Riverhead Books, and the Pulitzer Center, which is developing curriculum materials for teaching in the classroom this epic story of our extended life. So we're using these conversations to explore additional avenues that we didn't get an opportunity to do as deeply as we would have liked in the series. And in many ways, episode 3 on data is the episode that, to me at least, seems the most resonant with the year that we've just lived through. First, of course, there's the critical importance of tracking the outbreak of COVID and flattening the curve and all that language that we learned, something that has been at the top of all of our minds since at least the beginning of March of last year. But then there's also the emphasis on health inequalities, as in the story of W.E.B. Du Bois in Philadelphia, or the investigation into inner city lead poisoning. These stories seem particularly relevant after a year where we spent so much time talking about systemic racism and Black Lives Matter. So to explore these two themes, we have two fantastic guests to join us here today. Dr. Lauren Smith is the Chief Health Equity and Strategy Officer for the CDC Foundation. She partners with the CDC Foundation's other senior leaders to develop and drive strategic efforts to embed health equity across the Foundation's COVID-19 response activities with an explicit focus on addressing systemic racism and its impact on vulnerable populations' resiliency amidst a pandemic. So obviously perfectly suited for this conversation. She was previously medical director at the Massachusetts Department of Public Health. And also we have Caitlin Rivers, who's a senior scholar at the Johns Hopkins Center for Health Security and an assistant professor in the Department of Environmental Health and Engineering at the Johns Hopkins Bloomberg School of Public Health. Her research focuses on improving public health preparedness and response, particularly by improving capabilities for outbreak science and infectious disease modeling to support public health decision-making. Great guests, Lauren and Caitlin. Thank you so much for joining me.
Thank you for having me.
So, many people who are watching this right now will have just seen episode 3 on data. And this is an interesting one because it's not focused on a tangible object. When we think about health breakthroughs, we often think about, the vaccine or the pill that you take, the penicillin antibiotic. But one of the arguments that we make in the show that is obviously central to the both of you in your work is that sometimes there are less tangible breakthroughs and new ideas and new approaches that can make just as big a difference. And the revolution in kind of data science and looking for patterns in health data is certainly one of those cases. And I just thought, I was curious to hear, since you have, your whole, both of you, your careers have been devoted to this question, watching those stories in the episode, what stood out to you?
I was really reminded of how central data and analyses are to epidemiology. The field was really founded on the innovations that you cover in the episode, and it really underpins all of the work that we do in epidemiology. There's a lot more attention these days focused on things like developing the next vaccine, making sure we have therapeutics and diagnostics at hand, and all of those things are really important. But in the end, what we start with is data, and the insights that we gain from data are how we can start to intervene on the outbreak even before we have a vaccine. And as you mentioned, I think we haven't had as many innovations in data as we have in the so-called medical countermeasures, the vaccines, the drugs. the diagnostics. And so even though we really started with data, I think we have more to go, and I think we can put even more emphasis on making sure that we have all of the insights that we need at hand to respond to outbreaks efficiently and effectively.
I love that. And first of all, I want to congratulate you. I thought that the episode was really exciting and very interesting. So I very much
exciting
enjoyed.
Television about data science is generally not.
Well,
something that happens a lot.
yeah, exactly. But there you go. I guess the only thing I would sort of add to what Caitlin said is that what struck me was the necessity of both having the information and then determining what to do with it and how to make a coherent story out of it. Because there's one thing to have data, and it's a completely different thing to make meaning out of it and to use it in a strategic way to really understand what's at the heart of what's going on. And I think that one of the things that, struck me was that you needed to have all of that. And I think sometimes people misunderstand that data is just about collecting information. But, information alone doesn't solve anything. It's really the additional meaning making that has to happen.
Yeah, that's a great point. Well, both those points I think we can build on in this conversation. So much to dive into here. I want to start with the COVID experience and the use of data in the middle of an emerging outbreak. That's the point at which, in a sense, even in modern times, we're the most dependent on data. The vaccines are still months away. In the past, of course, they were years away. Now we can talk about months for vaccine development, which is an amazing breakthrough, as we saw in our vaccines episode. But in those early days, you don't have therapeutics, you don't have a lot of resources, but hopefully you do have some sense of who's getting the new illness, where they are, where it's spreading, and that the data, in a sense, is the first line of defense. When you look at what we lived through a year ago in those early months of COVID, what about the data, both collection and analysis, could we have improved on, and what would we want to see in the kind of if we have to go through this again, what could we do better?
Data early in an outbreak is always really difficult because we don't have a great sense of what we're looking for, and it's difficult to put out the message of what public health officials want to hear about, and it's difficult for healthcare workers or providers to kind of know what to report in. And so often outbreaks, the first data we get from outbreaks are reports from astute clinicians about something they're seeing that is unusual. And that was the case when SARS-CoV-2 first emerged. We heard of a cluster of atypical pneumonia of unknown etiology, which is a wonky phrase that I think perks up the ears of a lot of emerging infectious disease epidemiologists because it recalls SARS and severe influenza and a lot of other things that we are not excited to learn about. And so when a cluster like that is reported, health officials have to decide what sort of information or what sort of call they want to put out to clinicians to get more information in. This sounds like an easy process, and in some ways it is. You have a sense, okay, pneumonia, no other explanation, maybe you want something about fever, but narrowing it down from there gets quite difficult. Do you want to hear about all kinds of pneumonia? Do you want to narrow it down to people who have some sort of shared exposure? In the case of the early reports from Wuhan, there was a food market that was linked to a lot of the cases. Making these decisions about what kind of data you collect is really tricky, but it's also really important. If you don't set the right case definition, you may be missing cases, you may be missing something about your understanding, and it can really slow down the response. So one thing I think we could do better as a public health data community going forward is spend some time setting more standards around what kind of data we want to collect early in an outbreak. Right now, it's largely up to the local public health officials to make those determinations, but if we put some thinking in ahead of time, which we do already do, but I think we could go even further, it could make those early insights even richer.
Lauren, what was your sense of our response in terms of the data collection in those early days of COVID?
Well, I think that, all of the things that Caitlin points out is true. And I think that one of the issues with a coherent data collection plan that, Caitlin, that you're recommending is that we have a fairly disjointed or sort of federated public health system. So we have public health at the state level, down to the county level, and then at the city level. And all of those different health jurisdictions have different approaches to and different capacities and resources to be able to collect information. So I think one of the things that I would say about what has to go hand in hand with what Caitlin is recommending is a recognition and an investment in the public health infrastructure so that people are in public health at all those different levels are prepared to be able to gather the information that Caitlin's talking about in a consistent way, and that they have the means to do so. I think one of the things that we saw is that there was such variation because so much of it was left up to the different jurisdictions, and they differ widely in their resources and capacities.
Isn't one of the issues here as well that we are, particularly in the early stages of something like a new outbreak, we're dependent on the healthcare system, like clinics and hospitals, to report a lot of this data. And so when you have an epidemic like COVID that is disproportionately influencing low-income people, African Americans, that's a group that has less access to the healthcare system, and so we see less of that information. The groups that are the most at risk are actually feeding the least amount of data into the system. Is that one of the issues that we're wrestling with in something like COVID?
Well, I think that, COVID, well, when an illness is serious enough to require hospitalization, even if people don't have great access to primary care and other care, it's a morbid thing to say, but, people generally, when they're seriously or critically ill, manage to get into the hospital, because here in the United States, that's, where if it's going to be a fatal event, that's where, it's going to happen. So I think that people ultimately got there. I think the problem was the delays in getting there and the status or, the severity when people finally got to the hospital in the groups that are particularly at risk, as you were talking about. But then I'm sure Caitlin's going to speak to this, the question of how do we collect information about important factors like, racial categories that we know stand in, not for biologic phenomenon, but for experiences and risks that are recorded based on one's experience of race. And we know that we did not do a great job of that.
I absolutely agree with Lauren's comments. In the United States, we were very late to recognize the disproportionate impacts on people of color, on essential workers, and it's largely because we didn't collect and analyze that information to the best of our ability. And I think that's not a mistake we will make again. I think ensuring that marginalized communities, those that are not as able to access public health or medical services, and how we can account for that in the data will be really critical going forward. But there is one other comment that Lauren made that I want to pick up on, which is the observation that often the cases found first during an outbreak are the most severe. And that's because they come to the attention of the medical system, and that is where the cases are identified and counted. And it's a really tricky challenge early in an outbreak to understand what is the rest of the iceberg. How many people are there with mild illness, and how can we collect that information to develop a full understanding of what's happening in our communities? We saw during COVID that it was largely, again, severe cases that were ascertained, but as more and more cases were found, the proportion that were severe did decline. And that is a common phenomenon seen across outbreaks that I think is really important to get our arms around to really understand how severe the situation is.
I would think it would be particularly important with COVID, where, one of the signature properties of this virus and the disease itself is that asymptomatic spread, or the number of people who have moderate to no symptoms at all, but who are capable of transmitting it. Clearly that was a critical factor in its ability to spread around the world so quickly. And one of the things that, yeah, go ahead.
I was going to say, and that raises, you may be getting to this, the idea of contact tracing and why it is, important and staple of epidemiology to assess that, because that getting the information about how many people in that a exposed or indexed person, has, or that might also be positive, allows you to assess that. If you only get information, as Caitlin was saying, on the people who are sick enough to be hospitalized, you have no information at all about whether or not you can be asymptomatic or what the full range is. And contact tracing does help with that.
When I was in the middle of working on kind of prepping for the show and finishing up the book, I did a piece about data for the Times Magazine that I interviewed Caitlin for in May of last year, as this was all, we were still in the early throes of it. And the thing that really became clear to me, and we talked about this a little bit in the show, but the thing that really became clear to me is there's this timeline of an infection. And, you get infected on day one. In the case of COVID, you may be capable of spreading it by day 3 or 4, or whatever it is. And, the average person who ends up getting sick enough to go to the hospital shows up day 10 or wherever. And if they die, they end up dying on day 30 or whatever. But that timeline, where you collect the data in that timeline, where public health kind of intervenes to say, oh, we have a sick person here, we have an infected person here, is so crucial. And so much of the battle is shifting it earlier in the timeline, because if you intercept it at an earlier stage, they know that that information can be shared, they can be contact traced, the neighborhood community can find out about it. So that was something that had not been clear to me until living through COVID. And I'm wondering about the technologies that are out there potentially to help us shift that kind of identification, data collection moment earlier in the timeline. How interested are we in, there's some discussion about smart thermometers that were able to detect unusual outbreaks of fever. There's sewage surveillance that we talked about a little bit in the show. Is this a really interesting avenue of exploration that we're going to see a lot of progress, or is it better to focus on more traditional methods?
I'm definitely hopeful that new data technologies will improve our ability to detect and forecast diseases. I like to draw a lot of parallels between disease forecasting and weather forecasting. And one of the innovations that really pushed the accuracy of weather forecasting forward, really took it from a coin flip to the kind of accuracy we enjoy today, are weather satellites and other environmental collection strategies that were able to inform the weather models and make them more accurate, and scientists were able to iterate on that information. I think there's a lot of opportunity to bring those weather satellite equivalents into disease forecasting. Diagnostic technologies, you mentioned wastewater is a good one. Wearables on the show, I think, is another exciting opportunity. There might be environmental collection opportunities too. For example, we know behavior plays a huge role in epidemiology, unlike in the weather, where it's going to happen whether you are pleased with that decision or not. And so being able to collect data on how people are reacting and moving in the community, I think, could be important. I think there's a lot of opportunity for growth there that I'm really excited about.
Well, let's talk. I mean, the weather analogy, you brought it up, Caitlin. I think one of the things that has been fascinating to me about your work is that you've been arguing for some time. We talked about this in the spring of last year for that Times Magazine piece. You've been arguing for the creation of a kind of a center for epidemic forecasting, the way that we have the kind of Weather Bureau making forecasts about storms and tornadoes and all these things that, we've had some kind of weather forecasting for 150 years or something like that. And we have a lot of resources and centralized resources that are put into weather forecasting. So I guess my question is, why should we have that? But are we making progress? I mean, if there were ever a crisis that would seem to make the case for that kind of institution, I would think COVID would make the case pretty convincingly.
That's right. I do think there's an enormous need for a National Center for Epidemic Forecasting in the United States. As you mentioned, this could be something like the National Weather Service. but for infectious disease forecasting. Every time there's a major outbreak, whether it was SARS in 2003, Ebola in 2014, Zika, COVID, these events happen all the time, not to mention seasonal influenza. Decision makers ask, what's happening? What can I expect? What's going on? What sort of decisions should I make? And it is epidemiology that helps to inform those decisions. But with the advent of data science and with methodological developments in infectious disease modeling, it's often modeling and analytics that can help to support and provide those answers. And I think of this as a step beyond the analyses that are really central to traditional epidemiology. It's really about taking different data and making it greater than the sum of its parts to gather new insights and see around the corner. And so right now, those kinds of analyses happen all the time, but the structure by which decision makers actually are able to access those models is not set up, I think, as crisply as it could be. It's largely a volunteer effort. Many infectious disease modelers work in academia and they volunteer to support the response. That's not how we handle the military. That's not how we handle weather forecasting. We institutionalize those functions so that we have them fit for purpose and at the ready for an emergency. And I am really pleased with the progress that's being made in this area. On the first full day in office, the Biden administration announced an intention to create a National Center for Epidemic Forecasting and Outbreak Analytics. And there is also money for this in the American Rescue Plan, which is the supplemental funding package passed by Congress in March. And so we don't yet have details on when this will be stood up or what exactly we can expect from it. But I think that we are headed to a really exciting place, and I'm really pleased that we will have this capability on hand for the next emergency.
That's great to hear. Lauren, do you have any thoughts? Is that jive with your sense of
No, I
what we
think
need to
that
do?
it's great for all of the reasons that Caitlin pointed out. I would just add that there's the interplay between making sound use of all of your technology and then what is the overlay of, again, interpretation and sort of bringing sort of experience to the understanding of what the information is that's being shown to you. I just will, a quick story. When we were experiencing H1N1 in Massachusetts, another pandemic that fortunately was not as nearly as fatal as the one that we're living through now. But at the beginning, it wasn't clear what it was going to turn out to be like, and it was engendering a lot of concerns. And one of the things that I recall was that there was information that was coming in about pregnant women in Massachusetts who were hospitalized and were very seriously ill. So they were in the ICU, intubated, on a ventilator. And the numbers, it just didn't quite seem right that there were that many pregnant women, because I was getting the daily sort of, tick of, who was hospitalized. And so it took that connection of like, that doesn't seem right, or something doesn't quite seem normal, to then we were able to then go and investigate further and then create a response, which we haven't gotten to, of alerting OBGYNs and other practitioners that pregnant women did in fact have substantially higher risk of serious disease. So your approach to caring for them, your approach to testing, having a heightened level of suspicion, not sending them home to just hang out, should be different. And so I think that combining of the surveillance and the tracking that Caitlin is talking about with the meaning making and then being able to make a response, I think is really important. And so in Massachusetts, we were able to put out this guidance in June, which was really, really quite early. The national guidance didn't come out until later that summer, about the increased risk of pregnant women, which was well documented.
That's a great story, Lauren. And I think, it reminds me of something that I've been saying a lot as the show and the book have been out, which is, part of why we did this whole project is to tell these stories and to remind people of the progress that we've made in society, and to remind people of the important role that public health officials play in keeping us safe. And the thing that I think is compelling about these stories is that, as what you just described in your own experience, is that on some level they're mysteries, right? There's an unusual pattern that doesn't quite make sense, or you look through the data and you see oh wait, why is that happening? That's strange, and you have to explain it and then get the word out about it. That's why I think they actually make compelling stories in the long run, because people like to see people discern these patterns, like Needleman figuring out how to detect the long-term impact of lead poisoning, looking into children's teeth and things like that. And so I do think that there are compelling narratives that we can make that will resonate with people who are non-specialists in this field if we tell those stories. The other thing that I think for non-specialists that's interesting about this whole thing, and I think this speaks both to COVID and to the health inequalities question, which is there's a lot of lay interest in health data in 2020 and 2021, right? I mean, I spend every morning when I wake up and have my first cup of coffee, like the first thing I do is I have like 3 pages bookmarked that show, New York City COVID, positivity rates in terms of the testing and, number of hospitalizations, and then nationally. And I'm writing about this stuff, but I'm not checking on this professionally. I'm checking on this as a human being who lives in these communities and wants to know what's happening. And so, and the same thing I think is come out of the awareness that we have a disproportionate impact for things like COVID in communities of color in the United States, and being really aware of that data in a way that perhaps some of us weren't aware before. That seems encouraging on some level in the midst of all this tragedy, that people are paying attention to the numbers more, than they would have a year and a half ago. Can we build on that as we hopefully come out of the COVID pandemic?
It is really funny to hear just regular members of the community talk about like, oh, we're at 11 cases per 100,000 per day today, or what do you think the case fatality risk is? So that's been a big change in my life, is hearing those tools of the trade kind of around town. But I think one of the reasons I'm so excited about this Center for Epidemic Forecasting and building on some of the ways that epidemiology has become apparent to people in their everyday lives is because if we can better and more quickly understand what is happening in communities and get the word out in a way that is really effective, that reaches people where they are and is tied to actions they can take to protect themselves and their families, we can change the outcome of these health events, of epidemics. Maybe in a couple of years, as you check the weather to see whether you should bring an umbrella on your commute, you'll also check to see whether you should bring a face mask, because flu is really bad in your community. I think the more we can empower people to make those decisions and to help them to understand what the risks are, the better decisions they'll make, and that will in turn affect public health positively. And so I think epidemic data in the hands of the public with interpretation and with good public health communications can be really powerful.
And I would just add that throughout this whole conversation and the background, hopefully bubbling underneath, is a question of equity, because we know from a long history in both public health and in healthcare that when something new or effective comes along, there's usually both a time lag in how it diffuses into populations who have limited access. And the more effective the intervention is, the more important equitable access is for it, right? If something's not that effective, it doesn't matter that much whether or not people have access to it or not. But when something is effective or really important, then it becomes really crucial that there's equitable access. So, what Caitlin's talking about, how are we going to ensure that, everyone understands that they have the access to that information, that it is free, and that, there's bandwidth to be able to get it, even basic things like that. There are many folks who live in communities where they don't have the kind of easy access to electronic information that others do. And so if we build a system that inadvertently reinforces the structural barriers that create health inequities, we will not intentionally necessarily, but we will predictably reinforce those very inequities.
No, that's a great point, Lauren. Well, let's dive in more to this question of health inequities. So, I think I said at some point in the show, to me, this is one of those places where the life expectancy number is so powerful, is a kind of condensing down of so many different variables into kind of a single thing you can point to. there's a wonderful resource that's online. People can Google it and find it, but basically allows you to enter your zip code and see the life expectancy for that. I think it's technically census tract, but effectively your neighborhood. And you can jump 3 stops on the 2 train here in Brooklyn, and it'll drop 8 years life expectancy, and it'll go up 6 years if you go into wealthier parts of Manhattan. Linda Villarosa was in this episode, and she just had a piece in the Times about stretch 2 neighborhoods in Chicago where there's like a 30-year gap in life expectancy. That are, neighborhoods that are 9 miles apart. And I think that I don't know. That's, to me, that's the most fundamental form of inequality there is. Like, how much time do you have? And how likely are your children to make it to adulthood? So we've made some progress, but we have so much more to go. So I don't know, what are the most urgent things that we could do to change that, to narrow that gap?
Well, I think you raise a number of things, and I think that the idea of life expectancy, and then you alluded to the idea of whether or not your child lives to be 1, right? There's substantial infant mortality differences in the United States that put us, those women of color, their birth outcomes are really quite a bit worse than their white peers, and so this is despite having the kind of health system that we do, healthcare system. So I guess the first thing I would say is that our use of data really needs to be aimed at understanding what are the root causes of those inequities. And I think those of us in public health or in healthcare have done what I might say admire the problem. There's been a long history of documenting that there are substantial differences in practically any health outcome you could pick. The epidemiology is strong for that, for across many different communities of color and others. But then the question of how did that come to be and why, that's the sort of needing to understand the root causes. And so collecting and thinking about data that will help us understand that. And then the next thing I would say is that when it points us in a direction, we have to be willing to take a breath and go all the way there. So the pieces in your segment about the structural racism that was playing out in Philadelphia, but you could pick any city, the Chicago example you gave, that's real. And I think very often we've wanted to sort of kind of stop at a more acceptable or less challenging place. Oh, it's behaviors. If we tell people, that healthy eating and not smoking is better, then, they'll do that. Or, it's individual choice, all these kinds of things, which, behaviors and choice are really important, but all that happens within a context. And I think your piece talking about what is the neighborhood level context that either promotes or detracts from health. Why does the zip code matter? It's because, digging in and understanding the underpinnings of that. And in the United States, I'll be quiet. I definitely feel passionate about this. In the United States, I think a key issue is how segregated our communities are. And that's something people take for granted. Like, they don't even think twice about the idea that our communities are so segregated. And with that segregation comes deep differences in investment in all of the building blocks one needs for health.
Yeah, that's really interesting. So on so many levels. So, I mean, it reminds me, there was a point when Los Angeles in, December was having a really bad, they were kind of peaking with COVID. And I remember thinking, as a New Yorker, I think of Los Angeles as very, New York is so much denser in terms of the overall distribution of the population than LA, and the weather is so good. And I thought, why would LA be having such a hard time? They can just, hang out, and they're also it's sprawl, and the weather's good. But then this fact came up, which I didn't know, which is that in terms of, in parts of LA, in South Central and other parts of LA, the actual, kind of people living per room in the houses there is actually higher than New York's. And so just like W.E.B. Du Bois had documented in the Seventh Ward of Philadelphia, when you see 5 people sharing a room, that is a terrible environment for,
infectious
disease, right? And the division between people living in those kinds of conditions and people living, in suburban mansions where you have 4 people in 5,000 square feet. I mean, that's a massive difference in terms of your ability to spread a virus, regardless, and that's not a behavioral choice, right? That's just the room you live in. And the difference there is so big.
I mean, Stephen, you can just layer onto that, the choice about whether or not you can work from home, or in order to make ends meet and provide for your family, you have to go into work. What kind of work do you do? Are you exposed to others, what we came to call the essential workers that work in grocery stores, work in food processing, run our public transit systems, all sorts of roles that aren't able to be done remotely. And those roles tend to be done by lower income people and people of color. And again, that's not random either. There's a legacy and a history of how folks get sort of tracked to different kinds of occupations, just taking occupations and the housing quality and housing conditions that you talked about, again, are another legacy of the residential segregation and other kinds of segregation that have left folks with less economic opportunities. So that the affordability question, why is it that people have to live so many people in a place, right? That directly gets at the affordability, wages, and, housing costs.
I guess my question to both of you is, what's clear in what you're saying, Lauren, and I think in the message we were trying to convey in this episode, is that there are deeper problems that have to be resolved that are not specifically at their root health problems. They're problems about the way society is organized. We may not even be able to get into the question of what's been called weathering and the effect of long-term chronic stress from living in a society where there's distinct amounts of prejudice on the body that clearly has deleterious effects. So there are these deep problems that can't be entirely solved from within a public health apparatus, whether it's our existing health system, whether it's a Center for Epidemic Forecasting, whether it's the CDC. So we need to commit ourselves to trying to solve those problems on those other layers through social and economic fights for justice. But what can we do from within the health system, since that's where both of you on various levels are kind of sitting? I mean, what are the most important interventions that we can make, with data or with other forms of intervention?
Well, quickly, one thing that I would add is that the recognition that the primary drivers of health outcomes, as you talked about in your session, are not happening in healthcare delivery sites. As a clinician, I'm saying that. So I'm not demeaning or diminishing the importance of healthcare, but as a primary driver of that life expectancy issue that you talked about, those aren't things that are happening in the healthcare system. So that means that the healthcare system needs to be aware of and thinking about data from these other domains. And that's where I think there's really exciting opportunity to mesh the data from other domains, where you can look at, the fast food restaurant density in a neighborhood, or is going to have or the food deserts What is the likelihood that people can actually, eat a healthy diet? Meshing that data with other kinds of clinical data, I think, is where the creativity can come to be able to act on this in a more structural way as opposed to a one-by-one individual way.
Yeah, I think Lauren has made really important points about why these issues go much deeper than something that can be addressed in a single move or a single day or even a single month. But in the context of the COVID response and what can we do today, even as we work to solve these larger issues, I think that the point she raised about meshing these different kinds of data together is really important. We saw earlier in the COVID pandemic, when testing was playing a really important role, that testing access was inequitably distributed. And by centralizing testing in places that were not easy to access, particularly for people who may not have a car or may not be able to leave work to access testing, by locating sites to places where they were easier to access, you could improve the uptake of testing and you could stop epidemics more quickly in those communities. And we're now seeing similar really important discussions around vaccine access, data around the number of people or the places in the country where vaccines are not easily accessible. What can we do to bring vaccines to those places? What can we do to meet people where they are and to acknowledge the realities about their work schedules or their transportation options and make sure that they have at their hands the tools they need to keep themselves safe? And I think data can really help to inform those decisions.
Right. They talk about the democratization of data, and I love that term both because, using data in a democratic way, but also recognizing that it will, how we do it affects, how it plays out, how we use the data. So I think everything Caitlin said, it makes absolute sense.
Well, this has been a fascinating conversation. I've learned a lot and so inspired by both of your work on this such important issues. I hope we have learned something from this pandemic that we will apply to not just the next pandemic, but to just ordinary life, everyday life, because we have a lot of work to do in reducing these gaps in health outcomes. So to Drs. Lauren Smith and Caitlin Rivers, thank you so much for joining me for this week's conversation. I just want to say we're especially grateful to the CDC Foundation for their help in putting these together, the nonprofit focused on saving and improving lives by strengthening public health protection through partnerships across the globe. Together, our impact is greater. We'll be back with a new conversation after the fourth and final episode. Hopefully there will be more at some point in the future, but for now, that'll be our final episode, which airs at 8 p.m. on PBS next Tuesday. I think that's June 1st. In the meantime, there are links below on this page where you can buy the book and get education materials from the Pulitzer Center. I hope that teachers are using some of these materials, including these conversations. We're sharing them with Pulitzer as well. And other information, you can learn more about the topics covered in this conversation and our panelists today. Thanks for joining us.